$100 billion in preventable medical costs each year is attributed to people not taking their medications. No wonder many proponents of medication adherence measures argue that if we hold doctors responsible for medication adherence, patient outcomes will improve. However, as with all quality measures, reality is much more complicated. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal, and I'm a primary care physician in Connecticut, and I run my own medical practice. In our American health system, we often substitute good intentions for resources that will move the needle in keeping people healthy. The Medication Adherence Quality Measure is another example where we've substituted good intentions for faulty measurement techniques and resources, making frontline physicians caring for patients responsible for medication adherence, which, as I will show you, is very much outside our control, especially given the resources we have. Let's dive in. The Medication Adherence Quality Measure specifies the percent of plan members with a prescription for a medication who fill the prescription often enough to cover 80% or more of the time they're supposed to be taking the medication. There are 3 medication adherence quality measures, and they all have the same anatomy. Measure DO8 for diabetes medications except insulin, measure DO9 for hypertension medications, which fall into the category of RAS antagonists such as lisinopril or valsartan, and measure D10 for cholesterol medications, specifically statins, such as atorvastatin or rosuvastatin. The denominator is anyone between the age of 18 to 75 years of age, and they're prescribed any medications for diabetes, RAS antagonists, for hypertension, or a statin. Next is the numerator, which is defined as people taking the medications more than 80% of the time. Since we cannot directly measure people taking the medication, a surrogate marker is used, which is called the proportion of days covered. It measures the total number of days supply of the medication filled by the patient within the measurement year and the total number of days in the measurement period. Confused? Let's do some math. You can see the formula on the screen. Let's take the example of a person who fills a statin on January 1st for a 90-day supply. The person has 2 or more 90-day refills and picks them up from the pharmacy when they're due. In total, the patient has received and filled a 270-day supply of the statin out of the 365 days. This means that the medication adherence was approximately 74%. Next, we have denominator exclusions, which include the patient is in hospice, has end-stage renal disease, or is on dialysis. For DO8, which is the diabetes measure, has 1 or more prescriptions for insulin. For DO9, which is the hypertension measure, has a prescription for a medication called Entresto, or the sample size is too small. The reporting period is between January 1st to December 31st, or more accurately, the measurement period starts on the first day the patient fills the prescription. The data source is called the Prescription Drug Event Data, which refers to the records submitted to CMS each time the patient fills a prescription. This data is submitted by Medicare Part D plan sponsors, that is, the insurance drug plans. The rationale for this quality measure is actually quite obvious. If people don't take their medications, their chronic disease will be uncontrolled, which then will lead to complications, which then will lead to higher costs. So we need to answer the fundamental question: why don't people take their medications as prescribed? The medication adherence is a complex problem with multiple reasons. These reasons can be intentional or non-intentional. Intentional reasons include the patient's belief system, which then itself can be multifactorial, such as the person feels they don't need the medication as they don't have any symptoms, for example, in hypertension. Cultural beliefs, or even a mistrust with the health system. Patient choice. Some people may make an informed choice not to take the medication. Side effects which may be perceived or real, such as fear of erectile dysfunction from beta blockers after heart attack, which a person might have read online. If the medication is expensive, people may or may not fill their prescription or skip days to make the medication last longer. It may be inconvenient to fill the prescription. Example, someone working 2 jobs may not be able to pick up the prescription from pharmacy when open. Or someone who travels for work for extended periods may not be able to get the prescription from a mail order pharmacy prior to traveling. And then there is advertising. People may stop using older medications such as metformin as they perceive the older medication to be less effective than the new medication, for example, Jardiance or Ozempic, based on advertising. And then there are non-intentional reasons, such as forgetfulness when people have dementia, low health literacy, and have difficulty understanding medication regimens or the instructions. This is especially problematic with complex medication regimens. Then people may not be able to take time off for their medical appointments, or the doctors don't have appointments available for several weeks to months. The patients may have a poor relationship with their doctor. And lastly, socioeconomic determinants of health, which include housing instability or food insecurity. The above list is a summary of the published literature. Most of you would agree that the majority of these factors are outside of control of doctors. One of the best models for medication non-adherence is the application of health behavior practiced in a social context model. According to this model, medication adherence is directly related to something called chronic stress burden. If the person has several other competing or even higher priorities that is stressing them out, then it'll impact if they take their medications. This chronic stress burden is a lot worse in people that don't have good social safety nets, such as education and social support. This, in turn, will also affect medication adherence. In one of my prior videos, the quality of quality measurement, I discussed that the gold standard framework for measuring quality is the Dunn-Abedian triad, which looks at three components: structure, process, and outcome. The medication adherence quality measure focuses on process, but the real reason for medication adherence is structural, that is, poor socioeconomic determinants of health. Creating quality measures under value-based care makes physicians responsible for socioeconomic determinants of health, turning doctors into social workers. Now that we understand the quality measures, let's look at the problems it creates for practicing physicians. Several medical studies have shown that medication adherence reduces costs and improves outcomes. However, these studies are retrospective and they rely on claims data, which is medical billing data, and that makes them prone to statistical confounding. The most significant confounding factor is that individuals who adhere to their medication regimens are also more likely to follow their other treatment plans, which is likely the primary reason for the lower costs and better outcomes. The reasons why people take or don't take their prescriptions is complex. These quality measures attempt to reclassify human behavior from the complex domain of the Kuhn-Levin framework to the simple domain. Since changing human behavior is hard, most medical institutions rely on gamifying the statistic to improve performance, which is called the Goodhart's law. The change in workflow to improve the statistic then increases the complexity of medical workflows, making the system much more dangerous and prone to errors, which is Charles Per's theory on normal accidents. Talking about making the system more dangerous and prone to errors, let's take a look at how the medication adherence measure makes the system more dangerous. Under the 2025 STAR measures, over 90% of patients must have a proportion of days covered, or PDC, of 80% or higher for the health plan to receive a 5-star rating. This is a high bar given all the problems I outlined earlier. The proportion of days covered PDC measure offers a convenient and readily available metric. However, it operates under the assumption that filled prescription data translates directly into medication consumption. This dependence on fill rate and the massive market opportunity to generate higher profits for health plans that achieve a 5-star status opens up the measure for gamification under Goodhart's law. Insurance plans and providers are incentivized to issue longer prescriptions, such as a 90-day refill or more recently 100-day refills, to improve prescription fill rates. So for example, a 100-day prescription with 2 refills, that is 300 days, allows the health plans to beat the target of 80%. You may be thinking that why is it a problem if I can get a 90 or 100-day supply of my medications? Why not give me just a 365-day supply and call it a day or a year? But there are unintended consequences of these quality measures. Pharmacies, especially those owned by insurance companies, especially CVS, often refuse to fill prescriptions for shorter time frames. Example, 30 days when doctors are titrating doses of medications. These longer prescription requests are not limited to medications covered by the quality measures, but often to all chronic medications. For example, I generally prescribe a 1-month supply for an SSRI for a new onset anxiety or depression and then titrate the medication to effect monthly so that I can use the lowest possible dose that works for the patient. However, I routinely get requests from pharmacies to convert the 30-day supply to a 90-day supply. A 90-day supply of the medication that people don't need after 30 days also increases the financial burden on patients as they end up paying for medications that they don't need. Paradoxically, this may then delay the doctor's ability to titrate medications, which may then lead to worse outcomes. When people have extra pill bottles, they may get confused about which medications they should take, leading to medication errors. People with extra medications end up sharing these with their family members or sometimes even selling them. People who receive these medications from family members often don't fill their own medications and then they may appear as non-compliant. And unused medications that are thrown away probably end up in a water supply. Under these quality measures, physicians are penalized when switching medications from one class to another. For example, for measure DO9, physician and health plan is penalized if the blood pressure medication is switched from a RAS antagonist such as lisinopril or valsartan to a different class, example hydrochlorothiazide or amlodipine, even if the patient's blood pressure improves. For measure D10, if the statin is discontinued due to intolerance or switched to another cholesterol-lowering medication such as estimebe, doctors are again penalized. Medication cost is a significant barrier for some people. People may choose to skip doses to try to make the prescription last longer, procure medications from family or friends, or obtain samples from their doctor. Or if they have the ability, purchase the medications from a foreign country. For example, I have several patients who routinely travel to India and will often purchase the medications there as it's cheaper. But then, I get dinged on the quality measure. To make matters worse, sometimes prescriptions are more expensive to buy through insurance than to pay cash outright. These cash payments are not captured in the administrative data. So the choice here includes the doctor gets penalized when patients purchase medications without using the insurance, or the patient is forced to pay a higher price by filling their medicine using the insurance. The Medication Adherence Quality Measure also penalizes doctors trying to manage populations with poor socioeconomic determinants of health. That is the homeless, those with low health literacy, and this was the entire reason for creating the quality measure. Patients who struggle to take their medications due to socioeconomic determinants of health will make their PCP look worse on paper. Due to the financial penalties attached to these quality measures, some of these people may end up being discharged from their PCP practices, who may then end up in the emergency room with complications. Now that we understand some of the problems of the Medication Adherence Quality Measure, let's consider some of the ways we can improve performance. The short answer is we can't do a whole lot in private practice, where doctors generally already have good relationships with their patients. The longish answer is educate patients on the importance of taking their medications. Simplify the medication regimen if possible. Use pill boxes or other reminder tools. Review the refill history in the electronic health record to ensure people are filling their prescriptions, and if they're not, find out why. Ask about socioeconomic determinants of health, especially if cost of the medication is a barrier. If the patient cannot afford the medications, have a list of resources to give them so that they can procure the medication. Remember, this may still penalize the doctor if the prescription fill data is not reported to the health plan. Prescribe a 100-day supply with 2 refills if appropriate, that is a 300-day supply. Or use a pharmacist if you have access to one so that they can help you. As with all quality measures, the unintended consequence of Medication Adherence Quality Measure likely outweighs any of the potential benefits. Furthermore, the quality measures are typically part of value-based contracts in which PCPs are forced to participate. Essentially, we've created a system in which PCPs are asked to control complex human behavior and address socioeconomic determinants of health without any resources or tools, under the threat of payments being withheld under value-based care. You can find a written version with references to the material and an audio podcast version on PCPLens.com. If you like this video, please sign up on PCPLens.com so that you don't miss the next episode when it's published. Thank you for watching the video. Take care and goodbye.